We'll just wait another minute or two for people to sign on. All right. Well, good morning, everyone, and welcome to Grand Rounds. And our speaker today is Dr. Bruce Dart, and he'll be speaking on social determinants of health. Dr. Dart is part of our CLEAR curriculum, and our program today is underwritten by an educational grant through OSU Medical Center, Graduate Medical Education. A disclosure statement has been signed and is on file in the Graduate Medical Education Office. Dr. Dart has served 5 local health departments in 3 states during his 40-year career in public health. Currently, he is our Executive Director of Tulsa City County Health Department, a local public health agency of 340 team members in Tulsa. Dr. Dart serves in a leadership role as a member of several National Association of County and City Health Officials, otherwise known as NACHO. And he has been NACHO's past president and former board member. He serves on the Public Health Accreditation Board, otherwise known as FAB, and their Accreditation Review Committee, as well as the Board of Public Health Foundation. He is a year 15 graduate of the National Public Health Leadership Institute, and his team was co-winner of the Martha Katz Award for Best Project. He has served an appointment as a visiting associate professor in the Oklahoma University College of Public Health. In Tulsa, he serves on the boards of the Child Abuse Health Network, My Health, and Morton Comprehensive Health Services, as well as the Impact Tulsa Leadership Council, and as an advisor to the Caring Foundation. He received his BA in biology from Drury University in Missouri in 1977, his MS in administration and health services from Central Michigan University in 1989, and his PhD in health services from Walden University, Minnesota in 2005. Please welcome my friend and colleague, Dr. Bruce Dart.
Thank you, Jenny. Really great to see you again. As you know, the pandemic has really impacted relationships. So I don't get to see Dr. Alexopoulos near as much as I used to. So looking forward to being on the other side of this. So let me share my screen. Can everybody see that?
Yes.
Okay. So we're here this morning to talk social determinants of health. It's it's an issue that I know many physicians. I've talked to many med students and first and second, third year residents who know that they have a, you know, they're goal driven people, they're highly motivated people, and they just want to take care of people. And you know, when we talk about social determinants of health, we're really talking about doing things more than just taking care of that acute issue that has that patient in your office this morning, and looking at that patient from a more holistic perspective to trying to understand other factors that might be impacting their health, which you as a physician has the ability to impact. So looking forward to today's conversation. We always like to tell people a little bit about Tulsa Health Department before we start our presentation. We want to everyone know what our vision is, which is to make Tulsa County the healthiest county in the country, which frankly, we're on a good pathway. Before the pandemic, I have no idea where we're at now, but you know, we exist solely to promote health and serve all Tulsa County residents and help East Tulsa County residents reach their greatest potential. And we do this, we make sure that not only our staff, but our community are aware of our values, and that we function under what we call the THC way, which is treat all people with dignity and respect, and we put our community first. So if you ever run into an employee of Tulsa Health Department, ask them these questions and see if they can tell you why we're here. So Dr. David Satcher, the 16th Surgeon General of the United States, somebody who I respect greatly, he said, the issue of health inequities is serious. Excuse me, it's a matter of life and death. It's time for leaders who care enough, know enough, will do enough, and are persistent enough to eliminate health inequities in our community. And many times this work really falls onto public health and healthcare workers like yourself. And it's important that we all function, I think, from a similar perspective so that we can deal with the issues that we see out in our community. And I'm sure that many of you have already been exposed to a lot of information, but you know, it's important to understand what health disparities truly are. And you know, Healthy People 2020, they define it as a particular type of health difference that's closely linked with social, economic, and/or environmental disadvantage. And health disparities affect groups of people who have systematically experienced greater obstacle to health based on their racial or ethnic group, their religion, their social economic status, their gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or any other characteristic that historically link them to discrimination or exclusion. So health disparities are driven by social and economic inequalities, and this slide lists things like economic stability, neighborhood and physical environment, education, food or access to food, access to healthy food, community, safety, and social context, healthcare systems that can all be impacted by racism and discrimination. So under economic stability, of course, there's employment, income, expenses, debt, housing, transportation, parks and communities. Does the community have infrastructure to help people be healthy? Do they have hiking and biking trails, bike lanes, sidewalks, parks, education, of course? You know, I used to say that education was the great equalizer. I think education can be, but structural and systemic racism still can hold people back. So education is extremely critical, but until we impact racism, it's still, for not everyone can be a catapult to success. We're really thrilled that you might have heard that North Tulsa has healthy food access issues. There's 35 food deserts in a 4 zip code area in North Tulsa. We just got a grocery store up there this summer. So that's, I think it's great news, but you know, one grocery store in an area of thousands of people isn't quite going to cut it. So we have more work to do, but it's great to see that work moving in the right direction. And then community safety and social context. So people have to have their social systems that should be integrated in communities. Everyone needs a support system. People need to be engaged. And we know that, when you're dealing with other issues, stress impacts your health. And of course, depending on where you live in Tulsa, there's greater exposure to violence and trauma in different parts of our community. And policing and justice is really varies from where you live in our community. And then, of course, our healthcare system, and hopefully between the ACA and now we have expanded Medicaid in Oklahoma, healthcare access won't be the issue it was several years ago. But you have to remember, even if we have everybody who has health insurance, has access to healthcare, Oklahoma still, I think, is 49th in this country in the ratio of primary care provider to patient. So even though if we have people who have coverage, we still need the physicians like yourselves to be here taking care of patients. So how can this affect health? And we look at things like economic stability and income. They directly shape nutrition and physical activity, our housing quality, stress due to inadequate resources to face daily challenge. I mean, the stress of putting food on the table every day for many families in Tulsa is tremendous. So of course, access to medical care, neighborhoods who directly shape safe places to exercise, proximity to healthy or unhealthy foods. There's at one time Tulsa was, I think, the test market for many fast food companies, and so the fast foods always seem to be stuck in certain proximity to in parts of our community where there was no other way to get out healthy food. So, and of course, fast foods can be cheaper than dining in other places. So, exposure to targeted advertising of harmful substances. We see tobacco advertising in disenfranchised part of our communities in more places than we do in areas that don't have these issues in our community. Proximity to schools and of course environmental exposure and education directly shapes standardized test scores, likelihood of graduating high school, likelihood of receiving or completing higher education, and frankly, it impacts lifelong income, resulting in lower earnings if you haven't been able to receive higher education.
Excuse me, Dr.
Yes.
Dart. Would you be able to go into presentation mode for us real quick? We're just seeing a partial of your slide. So if there's two ways you can do this, you can either hit down at the very bottom of your screen next to the slider where you can change the that thing. There's a little icon there. If you could click that for me, that'd be great.
Oh, I'm sorry.
No worries. Thank you
Can you
so
see it
much.
now?
Yes, sir.
As you can see, I'm highly technologically advanced. So as we look at the many markers of inequity, of course we have race, gender, ethnicity, labor roles and social class markers, nationality, language, and legal status, sexual orientation and or gender identity, disability status, geography, and religion. And it's important to note that these are risk markers and not risk factors. And just to clarify, while risk factors are those antecedents that are thought to have a causal role in the development of the disorder, risk markers are biological or neurophysiological traits that indicate a genetic tendency toward developing the illness. So that means a risk marker can be thought of as a form of risk factor that's not causal. So some quick statistics on poverty in this country. College graduates live an average of 5 years longer than people with no high school diploma. People with the highest incomes live an average of 6.5 years longer than people with the lowest incomes. The mortality rate for African-American babies in the United States is double that of white babies. And more than 45,000 people in this country every year die because they don't have access to health care. And 1 in 6 Americans are living below poverty line. And frankly, that was really data from early 2021, but we know with the pandemic, things are going to get worse. So the health impact of resolving racial disparities, 1991 to 2000, medical advances averted over 176,000 deaths, but equalizing that mortality of whites and African Americans would have averted 886,202 deaths. So just wrap your mind around that a little bit. So access to healthcare is extremely important. And then the prudence of investing billions in the development of new drugs and technologies while investing only a fraction of that amount in the correction of disparities deserves reconsideration. It's an imbalance that may claim more lives than it saves, and that's more work from Dr. Satcher and his group. So bottom line is that when you think about who is at risk because they don't have access, usually those are disenfranchised communities, our communities of color. And frankly, after all this time, it's amazing to me that we're still in this situation that we've been in for decades and decades, as far as our not serving everybody equally. So we talk about life expectancy, and if you're from Tulsa, you've probably heard a lot about life expectancy in the past 10 years. Life expectancy is the average number of years a person may expect to live when they're born. And one of the fundamental measures of the health of a community is life expectancy. And of course, the higher the life expectancy of a community, the greater quality of life in a community. And so we use these collectively with other life indicators to really determine our overall quality of life and our health status here in Tulsa. So we did have still have a life expectancy project. So we provided an update in 2006, and this update was called the Lewin Report. It highlighted life expectancy in Tulsa County. It shed light on improvements needed in specific areas of the community that have experienced some of our greatest disparities. Back then, it was very clear that people in North Tulsa live 14 years less than people in South Tulsa. I mean, so depending on where you live, work, and play in Tulsa, you have a 20-minute difference by car. You live 14 years less. So we use this report to inform policy and decision makers and other community leaders to really describe and hopefully promote the importance of collaboration to address health issues, because this is a community problem, and it's an issue that collectively, as a community, many parties must come together and decide that do we truly want to be a community where people do reach their greatest potential, or do we want a community where, through whether it be intentional or unintentional, people are held back? So we look at some of the methodology for things, some of the things that we've been doing with our life expectancy project. So the Center for Disease Control and Prevention best practice methods formula, we used data from 2011 through 2019 vet data, 2011 through 2019 population data and population estimates for additional years. And this data was analyzed in 3-year rolling totals, and that lets control for small numbers of deaths in our population, some of our age group of zip codes, where we have smaller numbers. And you see where the data was obtained from. So life expectancy over time in Tulsa County, of course, we have sadly a lower life expectancy than US. We had, so in increase or decrease in life expectancy in the US, we actually lost a tenth of a year. In Tulsa County, we gained one. But overall life expectancy in this country is 76.3 years. And in Tulsa, it varies across zip codes from 66.9 years to 81.4 years. 74137, which is in South Tulsa, has our highest life expectancy. 74130 has our lowest life expectancy. Now, when we first did the study in 2006 and 7, 74126 had our lowest life expectancy, and we poured lots of resources into that zip code, which improved greatly. But people who live in surrounding zip codes didn't get the same services as those in 74126. So when we talk about responding to life expectancy, we must have a holistic approach and assume that everyone who lives in a certain part of our community, based on this data, we have to ensure that we serve them equally across the board. So sadly, and we know we have health disparities, but in North Tulsa, they really persist. So we have issues around income. We have a much larger percent of population who live below poverty. Educational attainment lags in North Tulsa compared to other parts of our community. Teen birth rates are higher, but frankly, we're doing a lot of work around that. They are getting much better. And then mortality caused by death, which as physicians you'll see, really mirror, but the impact is greater in disenfranchised communities. Heart disease, diabetes, stroke, cardiovascular issues are becoming even more problem than they have in the past. So some of these things that are historically high on our list of cause of death seem to impact our communities with lower life expectancy greater. So I know as physicians, you all love charts, so we have plenty of graphs here for you, but just to show you the differences in some of our median household incomes. Now, when we do community health risk assessments at Tulsa Health Department, we break our county up into 8 regions so we can make sure that it's statistically valid and we're able to compare populations generally across our county. So, but if you look at so median income by region, Sand Springs, North Tulsa is only 43. You look at our Jenks region is up to 68. So we vary from 43 to 68 for medium income across our regions. Midtown's 50, downtown's 50, East Tulsa's 45, South Tulsa's 68. We have some disparities there, but as we go through these slides, you'll see that North Tulsa is sadly lowest in the good things and highest in those things that really impact quality of life. So percent of our population is living below poverty by region. North Tulsa is almost 30%. You go down to South Tulsa and Bixby, it's only 9%. So Owasso, Sperry's 9.5, Midtown 16, downtown's 23, East Tulsa's 18. So sadly, North Tulsa, the income disparity is also a huge factor that's impacting health outcomes. And guys, I have a tendency to talk really fast. I'm usually in a hurry, so if you need me to slow down, don't be shy. Just tell me. So teen birth rates by region, we have done some significant work from 2011 on, and we have dropped teen birth rates, but once again, North Tulsa continues to lead 25.1. And this, and these are our data. When I first came here, I was astounded at our teen birth rates. I've been here 11 years now, since late 2010. And as a community, we really have picked up our ability to impact this, and we've seen great success. But once again, we've got to do more work in those areas that are already impacted by health disparity issues and factors. So you look at things like mortality rates, heart disease by region, and as not to be unexpected, but I guess for many people it might be unexpected, but we look at North Tulsa, it's 277.9, this is 400,000. So Sand Springs is higher, our Midtown region is higher, and then Oklahoma as a state is higher. Tulsa County is higher. So there are some good things happening, and we're starting to make some changes. But what we're finding is that we focus all our resources on one part of our community. Other parts of our community, regardless of health disparity issues, still suffer. So we have to ensure that there's equal access to services across the board, across the spectrum, in all Tulsa County. So as I said, we do work. We try and measure what really is happening to our community. So we use a model. One of the models we use is the community need index scores, where we're trying to score really those parts of our community that are most in need and have highest risk factors for poor health outcomes. So when we do these things, we see some very persistent patterns. North Tulsa has high needs, lots of challenges, higher rates of mortality. Jenks and Bixby region and South Tulsa have low needs. They have higher incomes, higher educational attainment, lower rates of mortality. So when we look at the same metric and we see such a huge disparity, what creates that? And what can we do to impact those factors that are creating this gap in quality of life between various parts of our community? I mean, for me, it's unimaginable to live 20 minutes away from one part of our community and face such social ills in North Tulsa compared to South Tulsa. So we've got to do something to assure that, our mayor talks a lot about Tulsa being a world-class city, and there's a lot of work going on to make that so. Well, we have to do more work around health disparities if we're really going to reach the goal that everyone strives for. So, so that's a lot of bad news, and I tell people usually I'm the buzzkill in every room because sadly I bring too much bad news. But I want to make sure that everyone knows that improvements are being made, and the community and community leaders are paying attention. And there's many people in Tulsa who truly care about people that live here. So improvements in life expectancy may not be a direct result of improvements in healthcare access, but a correlation exists between access to healthcare and the well-being of residents. And bottom line is that we've teamed up with many community partners and city leaders and philanthropists and universities. Thousands of Tulsans now are experiencing a higher quality of life. So people come together, we share initiatives, we share investments, we steal your great ideas, we give you credit, but we steal them. We've created more greater access to community health clinics and that kind of thing. So when I first came here, I think there was one primary care physician in North Tulsa, which has changed tremendously. But it's people coming together and recognizing that we're only as good as our worst off demographics in Tulsa. And if we don't improve the quality of life for everyone, then Tulsa itself never improves. So what does health inequity and disparity look like in Tulsa County? And, look through the lens of racial and ethnic disparities. We talked about our median income in the past 12 months. So here's for race and ethnicity in Tulsa County regions in Tulsa County in 2019. So, and just for clarity, median household income is the midpoint in the range of reported household incomes. Half of households reported incomes above the median income, and half of the households reported incomes below the median income. So if you look at our white households, median income was almost $61,000. Our Black households, the median income was almost $33,000. It's almost double what whites make. Our Asian and Pacific Islanders are 61,000. Native Americans are 52,000. Hispanics, which we know, of course, is ethnicity, is almost 44,000. And so the difference between North Tulsa and South Tulsa, the median income in North Tulsa is 33, almost 33.5. South Tulsa, it's 72. So South Tulsa doubles the median income of North Tulsa, which, income is huge and one of those risk factors that really creates disparity here. So the population of percentage of population in poverty in the past 12 months by race and ethnicity. Our white population is 11%, Black population is 29.5, Native American 16.5, Asian 18.3, Hispanic 24. North Tulsa, 34.2% of all North Tulsa residents are below the poverty line, and South Tulsa only 9.4%. So it's our goal to see nothing in this metric, but until we resolve the gap, we can't solve the overall issue. So another risk factor for that impacts health status is single-family households and the percent of female-headed households by race and ethnicity. Once again, our African-American demographics are almost 50%. Our whites are 16.6. Native American is 26.5. Asian is 8.8. Hispanics 21.2%. And once again, the difference between North Tulsa and South Tulsa, that's almost tripled. So as you look at these factors that I think people don't think about, they really collectively combine to impact overall quality of life and health status for various parts of our community. And sadly, North Tulsa always leads our community in disparity. Percentage of civilian labor force unemployed by race and ethnicity. So once again, our Black communities in North Tulsa, 9.5% unemployed. White communities, 4.1. Native Americans, 5.8, and Asians, 2.6. Hispanics, 5.1, and you see the difference between North Tulsa and South Tulsa, once again, almost tripled. And so, yeah, at some point, I mean, we gather this data, we present this data, we look at these metrics, and at some point, you know, we have to do the work that eliminates those gaps. And that work was really well on its way. And it's continued as best as we possibly could during the pandemic. The pandemic has taken resources and attention away from these issues, and we're trying to put it back. And as a matter of fact, we had hoped to start our strategic planning process for our health department. Our former strategic plan, we achieved our goals. It was time to create a new one. We started in late 2019. Race, ethnicity was going to be the foundation, or health and equity was going to be the foundation of our strategic plan. And then we had to stop that plan with the pandemic. So we hope to take up, hopefully at the end of this year, and create a plan that not only has goals, but action steps to impact a lot of these metrics we're talking about today. So percentage of births to teens, less than 18 by race and ethnicity, and we talked about it a little bit, but you still see that our African-American populations continue to suffer more than anyone else. Now, our Hispanic populations are starting to come up in this metric. And so we've done a lot of work around this issue. It was doubled 10 years ago. So that's good news, but we know that teen births create a lot of children born into poverty, and many of those children don't make it out of poverty. So one of the best things we can do is to eliminate teen births, to ensure that those kids, and that's who they are, have the ability to be educated, to advance their lives without trying to raise a child. They do it as well. So, and then, you know, a sad metric that we have to change here in Tulsa is percentage of births with late or no prenatal care by race or ethnicity of mother here in Tulsa. And so, you know, this is too high across the board, period. But when you look at almost 30% of Black moms who are giving birth, either late or no, I mean, all these statistics really are way too high. So this is an area that we still have a gap. You look at the gap between North Tulsa and South Tulsa, but we have to assure that every mom, regardless of income, race, and ethnicity, have access to prenatal care, so that we start to change our metrics around infant mortality and low birth weight in our babies. Another issue that impacts health, of course, is percentage of moms who smoked during pregnancy. And you see the difference between our white, Black, and Native American, American Indian, Native American populations. And you see the big difference between our Asian and Hispanic. So certain demographics, and we know we have to do more work to ensure that those moms make healthy decisions while they're pregnant. And you see the difference between North Tulsa and South Tulsa again. So whether this is an educational issue, a cultural issue, a belief system issue, we have to change those factors that lead towards unhealthy behaviors, especially during pregnancy. So percentage of births to unmarried moms. You look at once again a huge discrepancy between white, Black, and Native American and Asian. Our Hispanic moms are once again starting to creep up in this demographic. So we have to pay attention to all demographics. And sometimes we focus too much in certain parts of our community, knowing that you know, we have pockets of other places, and we have to make sure that we're looking at our data appropriately, we're matching our data on the ground, and we're doing the work on the ground that needs to be done, so that we don't see gaps like this exist here in Tulsa County. So you look at the difference between North Tulsa and South Tulsa again, that difference is doubled. So we've got to change our culture, and this is starting. We look at issues that are behavioral and cultural, which are much more difficult to change. I mean, we can legislate behavior, can't legislate culture. So we have a lot of work to do in this end. The percentage of premature birth by race and ethnicity, and this is a huge marker of lack of prenatal care, and other factors that are creating poor health outcomes. But you see the difference, and once again, Black populations lead this metric as well. You see there's a much smaller difference between our white populations, our American Indian, Asian, Hispanic, once again, are going up. And you see the difference between North Tulsa and South Tulsa. And then infant mortality, as we talked before, is much, much too high. It's too high in our community, period. But our Black community have 18.5. I mean, that's a tragic statistic that absolutely has to change. And the difference between North Tulsa and South Tulsa. So, you know, we keep looking at this data, and we were seeing change before the pandemic. Pandemic, I think, has impacted a lot of our populations, not only socially and economically, but culturally as well. And also it greatly impacted our healthcare system. We're down something like 500 healthcare workers throughout our healthcare systems here in Tulsa. So our ability to serve these patients has also been diminished through the pandemic. Another social factor that impacts our communities are things like homicide death rates, and parts of our community which is flat aren't as safe as other parts. And our Black communities suffer at 46.9. They're much higher than white and all other demographics. So and what are the cultural issues that are leading to that statistics? You see the difference between North Tulsa and South Tulsa. And frankly, I've had a lot of residents of North Tulsa tell me that they get really frustrated when they see on the news there's been a shooting or whatever, and the TV reporters indelibly will talk about a shooting in North Tulsa. They won't talk but there's a shooting in other parts of the community. They won't specify where. It's just Tulsa. They won't say in South Tulsa or in East Tulsa or North or West Tulsa. And that's a source of frustration for North Tulsa and those who live there. It's just our words matter and perceptions matter, and we have perceptions issues regarding quality of life and those who live in different parts of our community. Stroke death rates, of course, our stroke death rates, our diabetes death rates, sadly they continue to mirror our and what impacts our specific population. You see that in our stroke death rates, our Native Americans have a higher rate of deaths by stroke, even more so than our African Americans. Once again, whites are almost our health. Hispanic is 22.4. So it jumps across the board, but you see our disenfranchised population who suffer the most. You see the difference in North Tulsa and South Tulsa. Same thing with diabetes death rates, much higher in African Americans in Tulsa County than it is in any other demographic. We knew that in our Native American, we had some work to do with diabetes as well. And of course, once again, the difference between North Tulsa and South Tulsa. So, you ask yourself as physicians, why do these metrics, why are they so disparate depending on where you live in North Tulsa? So we know that taking care of one's healthcare is only part of the issue here. We have to take care of other issues that impact people's health and quality of life. So, and once again, improvements are being made. And that's, I think, the positive thing is that lighter color indicates zip codes that have improved on half or more of the available of our indicators from 2011 to 2019. Darker colors are zip codes that have not improved on half or more of our indicators. So we look much different than we did 10 years ago. 10 years ago, this map was pretty much all dark. So we talk about the work that needs to be done. There is work going on, and improvements are being made. So achieving health equity, improved life expectancy is where you as physicians will really come in. So health equity is assurance of the conditions for optimal health for all people. Achieving health equity requires that valuing all individuals and populations equally and providing resources according to need. Health disparities will be reduced and potentially eliminated when health equity is achieved. So we have lots of challenges to achieve health equity. So it's important that those working on this understand the importance of history, historical gender inequality, racist policies, things like redlining, gerrymandering, those kind of things. Challenge the narrow focus of individuals. We need to change perspectives of people who live in our communities to figure, so that everyone has the same set of goals, understanding about what quality of life really means and what health equity really is. view systems and structures as modifiable. We've got to pivot and change how we respond to these health issues in different parts of our community. Transform consumers to citizens. Expose the myth of meritocracy. You know, meritocracy is that, you know, the myth that if you work hard, you'll be successful and you'll gain. And it's just based on the value of your knowledge and hard work and education, which doesn't always hold up, depending on your race and ethnicity and whatnot. So you break down barriers to opportunity. Everybody should have opportunities to succeed, and build bridges to opportunities to help people. And that's that helping hand that we talk about. So strategies for advancing health equity: improve the living conditions that are fundamental determinants of health, protect populations against disease promoting forces, support policies that create health promoting communities, and bring evidence to those who have the power to change policy. Policy is extremely important, and it's amazing what policy can do to affect the whole community as opposed to singular individuals. So it's important to understand what a community is or how it's defined. So generally defined by geographic location, city, county, metropolitan region. Some cases defined by target populations, men, women, children who serve, could be identity based. In some cases, take into account a hospital's principal function or special area of disease. So what we ask you as physicians is to know where your people live. Do they live in a higher risk part of our community? Know what their resources are. Identify health and social, economic, and environmental concerns, which I know you're trying to treat an acute issue with a patient, but these things are all contributing factors to that acute issue that you're seeing in your office today. Identify gaps in services for that patient. You know, physicians need not confine their activities to the client or hospital, but can also serve as effective health advocates and valuable resources for the community. The Oklahoma Medical Association has been tremendous in advocating for the right work to be done during the pandemic. We wouldn't be where we are today without that group of physicians leading the way. Partnerships with community groups, public health, and local leaders, using your clinical experience and research evidence to advocate for social change, and, you know, treating patients with dignity and respect, and creating safe places for disclosure so they tell you what you need to hear so you actually can serve them. So, you know, we need a day-to-day partnerships. We must respond as a community like we've done through COVID-19. All our Ph.D. divisions and programs interact with community partners on a regular basis, and hopefully we're identifying the issues and developing intervention and policies to move that needle forward. So you as physicians, you know, how to get started, and it's look for deeper causes, you know, look for issues beyond why they're in that office to see you that day. You know, and I know you, as physicians, you don't have a lot of time with your patients, but a little extra time per consultation to address complex health and social needs is really critical for that patient in your office, and really try to understand the local referral resources for specific social challenges. You know, focus on equity, find your partners, and the bottom line is that, you know, just do it. Know that you can impact your patients, and many times, you know, as you talk about these social challenges or other health issues for your patient, you have no idea, but that one conversation could change that patient's life for the better for the rest of their life. And you'll never know it, but all it takes is one interaction and tremendous things can happen. So any questions today? I tried to make it right at 45, so I think I got close.
Dr. Dart, thank you so much for fitting us in today, and appreciate you and the hard work of your team. You guys were doing a really heavy lift before the pandemic. I can only imagine the impact on the pandemic and your team. So please pass on our thanks to them.
Absolutely.
And we look forward to seeing you again. Thank you for keeping Tulsa City and Tulsa County safe with your messaging throughout this pandemic. And we're delighted that you were able to join us today. Thank you so much.
It's been a pleasure and an honor to be asked. Thank you.
Bye-bye.